Let's jump right into this explainer. Today, we're isolating the autonomous proliferation mechanisms of polycythemia vera and synthesizing them with some highly specific neurodegenerative chronologies. As clinical consultants, mastering these intricate mechanisms, the subtle traps, and the definitive markers is exactly how we flawlessly navigate complex real-world presentations. This review is strictly calibrated for top-tier clinical understanding, so let's start with the exact hematologic derangements that drive autonomous red blood cell proliferation. We have to begin with the kinetics of polycythemia vera, or PV. In roughly 90 to 95% of these patients, it's the JAK2 V617F mutation that dictates an absolute autonomous proliferation of red blood cells. Think of this as a primary myeloproliferative state. The bone marrow's pluripotent stem cells become exquisitely sensitive. They just start churning out red blood cells completely independent of normal physiological feedback loops. It's essentially a runaway train of erythropoiesis.
So, you might be wondering, what is the absolute laboratory signature we rely on here? Well, when you look at the diagnostic matrix for primary PV, you're invariably going to see a massive hematocrit spike. We're talking well above 60%. But here is the absolute defining feature. The parameter that proves this is a primary bone marrow issue is that the serum erythropoietin, or EPO, must be profoundly suppressed. The kidneys are doing their job, they're appropriately shutting down EPO production because the oxygen carrying capacity is so high, but the mutated bone marrow, it just completely ignores the signal. Now, this incredibly thick, hyperviscous blood translates directly into clinical symptoms. You'll see facial plethora, blurry vision, and a massive, highly elevated risk for arterial and venous thromboses. But I want you to notice the pathognomonic marker at the bottom there, severe aquagenic pruritus. This is intense, systemic itching that happens literally right after a hot shower. Why does that happen? Well, PV is a panmyelosis, meaning the white blood cells are elevated too. The hot water triggers massive histamine release from all those excess circulating basophils.
But wait, what happens if the EPO is not suppressed? If it's high, we are no longer dealing with PV. We've crossed over into the realm of secondary erythrocytosis. And this branches into two highly distinct pathways. The first is a hypoxic drive. Things like severe obstructive sleep apnea, COPD, or living in high altitudes cause chronic hypoxia, which drives inappropriate compensatory EPO secretion from the kidneys. But the second pathway, and this is far more dangerous, is the perineoplastic surge. This is autonomous, malignant EPO secretion driven by specific solid tumors. You absolutely need to watch out for renal cell carcinoma, hepatocellular carcinoma, and hemangioblastomas. And this brings us to a crucial clinical variance. You have identical presentations of an elevated hematocrit, but they diverge entirely on a single variable, serum EPO. In primary PV, you've got panmyelosis, meaning the RBCs, WBCs, and platelets are all up, alongside that suppressed EPO and a positive JAK2 mutation. In secondary erythrocytosis, you definitively see an isolated RBC elevation. The white blood cells and platelets are totally normal, the EPO is strictly elevated or inappropriately normal, and the driving force is either hypoxia or a masked tumor.
Okay, let's switch gears. Just as hematology requires precise diagnostic parameters, neurodegenerative pathology demands that exact same rigor. Let's analyze Lewy body dementia, which is an alpha-synuclein infiltrate of the brain. To formally diagnose LBD, you are required to identify a definitive clinical triad. 1. Fluctuating cognition and alertness. 2. Intense, highly detailed visual hallucinations. And 3. Spontaneous Parkinsonism. That includes resting tremors, rigidity, and bradykinesia.
The crucial differentiator here is the 1-year chronologic threshold. How exactly do we distinguish LBD from Parkinson's disease dementia when they both feature cognitive decline and motor deficits? It is entirely about the timeline. In LBD, the cognitive decline and those visual hallucinations occur concurrently with or strictly before the onset of motor symptoms. If established Parkinsonian motor symptoms have been present for strictly over a year before the cognitive decline even begins, the diagnosis shifts definitively over to Parkinson's disease dementia. Now contrast that with the frontal atrophy seen in frontotemporal dementia, also known as Pick disease. The massive clinical trap here is assuming all dementias start with memory loss, like Alzheimer's. They don't. In Pick disease, declarative memory is initially completely spared. Instead, the absolute presentation relies on severe, early-onset personality changes. The patient, who is often fairly young, between 40 and 60 years old, presents with extreme disinhibition, profound apathy, or compulsive behaviors. The pathology is localized entirely to the frontal and temporal lobes at the start. Let's look closely at the definitive imaging for normal pressure hydrocephalus, or NPH. What you're seeing here is massive ventriculomegaly. Those lateral ventricles are markedly dilated. However, notice the distinct lack of significant cortical sulcal atrophy. This is a disproportionate ventricular enlargement, and it physically stretches the corona radiata, disrupting the sacromotor fibers running closest to the ventricles. That mechanical stretching is exactly what directly results in the classic motor deficits of NPH. This gives us our next vital clinical variance, differentiating LBD from NPH. Both of these present with a combination of cognitive and motor decline, but the specific phenotypes are radically different. LBD features that spontaneous Parkinsonism and visual hallucinations. NPH, on the other hand, strictly presents with the triad of magnetic gait apraxia, where the patient's feet literally appear glued to the floor but their arm swing is preserved, urinary incontinence, and dementia. Furthermore, NPH symptoms, particularly the gait, will massively improve following a high-volume CSF removal via a lumbar puncture.
Okay, it's time for the master case. Let's test deep integration of everything we've just covered. Evaluate this profile. You have an adult male with a heavy smoking history presenting with hyperviscosity symptoms, specifically facial plethora and severe headaches. During your physical exam, you note a newly discovered left-sided varicocele. And here's the crucial detail. This varicocele absolutely fails to empty when the patient is placed in a recumbent position. His laboratory profile comes back, revealing a severely elevated hematocrit of 62%. This immediately flags a massive polycythemic state. His oxygen saturation, however, is completely normal.
Faced with this highly competitive option matrix, you must identify the exact next best diagnostic step. Your options are A. Genetic testing for the JAK2 V617F mutation. B. A CT scan of the abdomen. C. Carboxyhemoglobin level analysis. D. A bone marrow biopsy for panmyelosis. Or E. Polysomnography. You need to navigate past the obvious hematologic distractors here to find the true underlying pathology.
Let's execute this assessment choice by choice. The plethora, the headaches, and that huge 62% hematocrit are an aggressive trap, pulling you toward polycythemia vera, making choices A, the JAK2 mutation, and D, the bone marrow biopsy, incredibly tempting. Meanwhile, his heavy smoking history makes C, carboxyhemoglobin, and E, polysomnography seem like totally plausible secondary hypoxic drivers. But did you catch the subtle anatomical clue? A left-sided varicocele that fails to empty? Physiologically, the left gonadal vein drains directly into the left renal vein at a perpendicular angle. If it doesn't empty when the patient lies down, what does that mean? It strongly indicates a hard anatomical obstruction. Integrating this, a left-sided renal mass, specifically a renal cell carcinoma, is physically occluding that vein. This is a classic masked perineoplastic trigger autonomously secreting EPO. Therefore, this is strictly secondary erythrocytosis, not primary PV. The definitive next step is B, a CT scan of the abdomen. As we wrap up this explainer, I want to leave you with a thought to carry into your practice. When you look at a patient, are you just reacting to an isolated lab value, or are you truly evaluating the integrated physiological system sitting right in front of you?